Okay, so good evening, everybody, and welcome to this postgraduate lecture series. And today we're going to talk about a very interesting issue of hypernatremia. As you are aware, the postgraduate lecture series is focusing about different aspects of pediatric endocrinology, and we are planning over the next 3 years to complete about the entire aspect on that regard. So we had this 14-year-old girl who presented with failure to thrive. And actually at 14 days, she was lower as compared to the birth weight. And that's a very significant finding in that perspective. She was entirely breastfed and was found to have a sodium of 182. So this was a very devastating scenario, very difficult to manage. And what it was found out was that this was actually what is known as breast milk related hypernatremia, in that there was concentrated blood of a sodium very high and concentrated urine, meaning that body is trying to eliminate sodium but it is unable to. So this was a breast milk related hypernatremia, which is a lethal condition, a avoidable condition, which we should try to avoid if there is enough feeding evaluation in that setting. A second situation was more of a iatrogenic problem. A 3-month-old girl with altered sensorium was found to have hypernatremia, sodium of 170, and a urinary osmolality was low. Now, as I'll discuss in the first case, the main thing to look at hypernatremia is what is the urine. If you have a concentrated blood and a dilute urine, like in this case, your diagnosis of diabetes insipidus is already made, and you do not need to worry to do anything else. You have to go for an AVP response. Now, what unfortunately was done in this case was that they were advised a water deprivation test. Somebody who's already water deprived, who has a severe dehydration, if you do that, will develop seizures. So while we need to be careful in terms of assessment, we need to know what will be the right strategy. And this is what we'll discuss subsequently from that perspective. So hypernatremia is a relatively rarer condition as compared to hyponatremia, which we discussed last time. But this is one which is associated with significant complications in both in terms of assessment, in terms of management as well. And this was a classical case of DI in which we didn't need to do any water deprivation, and easily we could have made the diagnosis in that perspective. So today we are going to talk about a bit about pathophysiology. Then we'll talk about criteria and etiology by Dr. Sain. I'll touch base about evaluation and management. And finally, we have the Q&A session in which we'll keep it interactive. So all of you can put your answers and we'll see how well our class has gone in terms of that, in that scenario. All of you can go and have a look at our website, learning.growsociety.in, which has got multiple information pathways, courses with regards to pediatric endocrinology, YouTube site, which has got multiple videos, and a learning platform which provides evidence-based validated learning in pediatric endocrinology using practical tools for diagnosis and assessment in that regards. We specifically have a 3-year online and a 2-year offline fellowship program in pediatric endocrinology, along with pediatric endocrinology for postgraduates, specifically targeting the topics which are very, very relevant for pediatricians and pediatric endocrinologists in the form of growth, puberty, thyroid, calcium, electrolyte, and it has got a lot of interactive videos, texts, which are available from that perspective. We cover 3 specific free webinars every month in the form of specific to a particular topic, which is relevant for a pediatric endocrinology perspective, from a pediatric perspective, and finally, the postgraduate lecture series, which we try to cover specific topics. And we have a schedule which is there for the next 3 years, which will basically cover the entirety in that scenario. We've got publications, both basic and advanced pediatric endocrinology, to cover the entirety. And you can access our mobile application, which provides validated tools to evaluate, assess, and manage complicated endocrine conditions like hypernatremia.
We have mainly, as sir has just now said, we have either a deficiency of free water or a sodium excess. And the causes in the bottom half of the screen, that is low free water, will be the overwhelming majority of the cases. So let us now move forward to the etiology of hypernatremia. Now, coming to the causes of reduced free water, which sir has just mentioned in the last slide, it can be due to reduced intake. Now, when do you have a reduced intake? It can be only in cases where the child does not have free access to water, that is in case of neonates, or in cases when the child has been completely knocked off. Like imagine a situation where the child has been admitted in the hospital due to a trauma, or is in the setting of a post-operative phase where it doesn't have any access to free water. The other cause, which is the most common cause we generally get, is the cause of increased loss of free water. And what is the most common cause of increased loss of free water? It is in the setting of diarrhea, where we have extra renal causes of loss of free water. And in this situation, how will you diagnose the case? All the causes of reduced free water have dehydration as the presentation. So the body will try to conserve all the volume and the sodium. So in this situation, you will have a urinary sodium of less than 25. Now coming to the other causes, that is the chronic cause of increased free water loss or the endocrinal causes of increased free water loss, you will have the diabetes insipidus or the osmotic diuresis, which you generally will have in a post-DKA setting where the child has increased glucose, has been given mannitol to prevent cerebral edema, and this leads to increased loss of free water. But in this situation, in the situation of osmotic diuresis, you don't have to worry because as you correct the sugar, the child will automatically improve. Now, the next situation of increased sodium load, as sir has already mentioned, this is one of the rarest of rare causes of hypernatremia. The causes of excess sodium load or inappropriate ORS is very rare. But to have hypernatremia due to endogenous hyperaldosteronism is all the more rarer because sir has just now said, because whenever the body takes in more sodium, ANP comes in, drives out all that excess sodium from the urine. In these cases, therefore, you will have increased sodium in the urine of more than 25. But the clinical pointers to differentiate reduced free water and sodium load, you have to check for dehydration. So if the patient has dehydration, you can be sure that the patient has reduced free water. Alongside, if the patient has signs of fluid overload, you can be sure this is one of the rare causes of sodium load causing the same. Now, moving forward to the first case that sir mentioned is of a neonate presenting with hypernatremia. Now, what is the cause of this same? These patients generally are born to primigravid mothers. These mothers generally have decreased fluid intake, thereby causing decreased free fluid in the baby, leading to rise of sodium. So this is generally a firstborn child presenting at 2 to 3 weeks. Now, all children have loss of water through the urine in the first 1 week. Thereafter starts regaining, and term infants generally regain by 2 weeks and preterms regain by 3 weeks. But if the child persists and has failure to thrive, even after 2 to 3 weeks, has dehydration along with, and you check his electrolyte levels and you see a sodium that is very high, around 170, 175, you can have a diagnosis of breast milk hypernatremia in these cases. Moving forward to the next cause of adipsic hypernatremia, this is the point which sir again mentioned, is of those patients who don't have control over their thirst center. It might be due to any developmental anomalies in the brain like holoprosencephaly or craniopharyngioma, or might be in the typical setting of a post-traumatic phase or a post-operative phase. Now, as sir mentioned, even if the thirst center is inactive or not working as such, if your renal mechanism is working, that is, if you have enough AVP secretion occurring in the patient, you will not go into drastic hypernatremia. But if the situation is also associated with DI, as can occur with any patient of malformations of the brain alongside holoprosencephaly or craniopharyngioma, you can have DI. So these patients will be the most severe. That is, if you imagine a tank, the tank is not being filled, that is, the child doesn't have thirst, cannot replete his fluid status. Along with that, the tank is leaking. So the fluid is also going out. So these cases will have the severest of dehydration and the severest of hypernatremia that you will ever get. Moving forward to the most common cause of free water loss that we generally manage in the OPD or in the ICU is of secretory loss. Now, secretory losses of free water is more with rotavirus. In the contralateral setting, if we have a secretory diarrhea with Vibrio cholerae, we have isotonic fluid losses, but rotavirus specifically causes more H2O losses, causing alongside a rise in free sodium. Alongside, many cases has been seen is that you have a secretory diarrhea causing free water loss and you give inappropriate ORS. So this situation, you can very well imagine that the sodium levels of the child will increase. And one more thing, A hypernatremic diarrhea generally has a lower symptoms because the intravascular volume in these cases is preserved. So you may misdiagnose the level of dehydration in these cases, that is less apparent dehydration. Coming to the osmotic diuresis part, which I already mentioned, is of a sugar and mannitol. Now, when does this situation typically arise? Is of a diabetic patient going into decay, having features of cerebral edema, and we give the child mannitol. So typically in a post-decay setting, a resolving phase of decay, that you generally have osmoles taking up the free water and thereby causing rise in the sodium. Now, these patients all have high urine osmolality, but as the osmoles are apart from sodium, you have a low urinary sodium in these cases. Now, the most common cause of chronic DI, chronic polyuria or chronic hypernatremia that we face is of a diabetes insipidus. Now, in these situations, you have an impaired AVP effect, that is either a decreased AVP secretion or a decreased AVP action. Now, as AVP cannot work, the free water is excreted by the urine in tons and tons. Now, what happens? Free water decrease, contralateral sodium increase. But if the thirst center is active in these patients, you will have only the symptoms of polyuria, polydipsia, no hypernatremia. These patients will have a concentrated blood, but will have a low urinary osmolarity, making the diagnosis of DI. Yeah, this is what I said. So a high serum osmolarity in any situation with a low urinary osmolarity, you can have a working diagnosis of DI to work with. Now, what are the causes of DI? Two major causes. One is decreased secretion. The other is decreased action. So central DI versus nephrogenic DI. Now, the first causes, that is the congenital causes of central DI. These are the most severe causes presenting immediately after birth. Now, these patients also have craniofacial malformations. Now, I had one such child during my PGT days, but I didn't recognize the child. The child typically had a single eye, had a proboscis, and had cyclopia essentially, and was pouring in lots and lots of urine. But it didn't strike my mind at that point of time that it was essentially a case of MPHD. So very early onset DI, think of genetic causes. Very rare you can have isolated AVP gene defects causing central DI. Now, leaving aside the congenital causes of central DI, coming to the acquired causes of central DI. If there is any insult like trauma, surgery, or brain, these are acute, like it will happen immediately. So acquired causes of DI happening immediately, think of trauma or post-operative phase. If the situation slowly evolves with other disease manifestations being much more, think of other diseases causing DI. Typically in the setting of a early childhood, a patient 2 to 5 years of age presenting with rash, seborrhea, think of LCH. Having manifestations of TB, very sick, think of meningeal TB, think of brain TB. And you can also have germinoma or a craniopharyngioma evolving over time. Now coming into the nephrogenic causes, before thinking of nephrogenic DI, always rule out the transient causes of the same. Now the causes have been mentioned: hypokalemia, hypercalcemia, or any drugs causing the same. So first rule out transient causes of nephrogenic DI and then come into the causes of congenital nephrogenic DI. These patients also present very early, typically in neonates. You will get these patients in neonatal age or very early infancy, while central DI typically presents after 1 year age. So neonatal complaints, very early infantile complaints of DI, think of nephrogenic DI. The causes of which are vasopressin receptor defects, aquaporin defects, can be other syndromic causes of Barter's or Bardet-Biedl syndrome. Any acquired renal insult occurring due to obstruction, sickle cell anemia, also you can have a nephrogenic DI in the same. Finally, coming to the most rare cause of hypernatremia, that is of a sodium load. Now, when the body has increased sodium, the sodium in the blood also increases. Immediately, the volume increases in the blood. The volume goes and stretches the atrium, having immediate release of ANP. Now, what does ANP do? It immediately takes off the sodium from the body and you have restoration of normal volume. So, Any cause of increased sodium will not present immediately with high sodium levels. As sir mentioned, in the typical setting of RAS excess, you will have a presentation of metabolic alkalosis, hypokalemia, and increased BP, but not with hypernatremia causing the same. And this is why this disease is self-limiting.
Come up, you can all go and have a look at our website, applications, and books. I'll really thank Dr. Naveen and Dr. Sayan for being part of this program, and they've really made it very, very interesting.